So without further ado, will you join me in giving a warm CPC welcome to Dr. Alexander?
Thank you.
Thank you.
Yeah, I'll just kind of reintroduce myself very quickly for those that weren't there, or just to refresh. So I am an infectious diseases clinical pharmacist at the University of Nebraska Medical Center. I'm here in Omaha, Nebraska. We've been kind of a preeminent medical center and infectious disease team with respect to the pandemic, and really with respect to bioterrorism and biological threats of all sorts infectious for decades. And so my role is in taking care of COVID patients, inpatient, outpatient, at the medical center, as well as working with the state of Nebraska. I was appointed to be.
How do you get it on the speaker? Just turn it on.
I was appointed to be the leader for the distribution of COVID-19 therapeutics for the state of Nebraska. So I've been working with the drugs like remdesivir and the monoclonal antibody products as they've been allocated throughout the state. So I've been in charge of that. And then also making, protocols, processes, procedures for the medical center specifically in the way that therapeutics should go. And then more recently in working on vaccine distribution, again, at the institutional level. So I have a few different roles at the institutional level, obviously, but then also a little bit involved with, significantly involved with the state distribution of therapeutics products. So not vaccine at the state level, but drug products, which is my specialty. So really, yeah, kind of like last time, if you were here, I think my preference is actually to just get your guys' questions answered. So what I'll try and do is be as clear as possible where I know things. Again, my specialty is really in therapeutics, but I've been, reading and I'm immersed in all things COVID. So I'll be as clear as I can in answering questions and telling you what I know. I'll tell you if there's something that is known, but I don't know it. And I'll tell you if something is not known at all. And if I can be clear about those kind of three aspects, then hopefully that will lead to some good communication. So I think I'm happy to just take your questions and we'll kind of, answer as many as we can in the time that we have. I enjoy that. And probably that leads to you getting as much information and out of this what you want. So.
That sounds great, Bryan. And just for everyone's sake, if anyone doesn't feel comfortable speaking up, you're welcome to use the chat function. I'm happy to kind of monitor that. And other than that, you can, just speak out or raise your hand, or there's the digital hand you can raise. So please, yeah.
It seems like the incidence of the disease is trending down. Is that your impression?
Yeah, absolutely. Nationwide, the disease is trending down in incidence over the last, I would say, month or so. There are very few states, actually some around me, Nebraska, South Dakota, Kansas, I think, where had slight increases. We haven't here in the Omaha area, but very few places in the country where actually disease is even flat. So yeah, incidence is coming down. Now, what's interesting is we can't really explain why. I mean, you'll hear as many possible explanations for why we've seen such a significant decrease over the last month or so, as you would have people to explain it. So I'll be quite clear in saying that we don't really know. Is it because, some more vaccine penetrance? Sure, but the number, the percentage, 5-7%, whatever, something like that, in terms of the total population vaccinated fully, probably isn't enough to by itself move the needle. We're still in winter, so behaviors probably haven't changed very much. So we really don't know why, but that's part of the disease process. Lots of things we don't know. So
do you expect that the incidence will increase with the new viruses coming around?
I mean, that's the concern. If I have to say everything is positive, the only thing with this disease process at the moment that is not positive is the new variants. And really, I want to try, again, this is one topic on which, if we talk about it a little bit, I want to be as clear as I can, because I think that it's very easy to sensationalize data around the variants and what their impact is going to be. And I don't want to do that. I think that the communication from public health officials should be that the variants are of concern for us, and they can be a concern in the sort of intermediate period if we do things poorly. But if we continue on the trajectory that we're going, which is increased vaccination and maintaining our public health measures in the near to intermediate term, the variants will hopefully not make a huge impact. And again, if you're interested in talking more about that, I'm happy to do that. But I want to be clear that it's really, I would say the variants are not something for the public to be too concerned about, because if we get our vaccination rates up and we continue to distance and wear masks in the interim, the variants will probably have minimal impact in the long term on what happens with this disease.
Great. Who else? Was it Marilyn?
I have a question, Scott. It's a personal question, though. We're hoping to go see our daughter in Idaho, and my husband has had his second vaccine, and I will hopefully tomorrow. And this will be after a month after that. And our daughter's husband has had the second vaccine, but she had COVID, but she's too young to have a vaccine. So the question is, do we wear can we act like we're family? Do we have to wear masks and be 6 feet apart in the house when we visit? We'll obviously be careful in the airplane and all that stuff. We'll follow all the rules, but we don't know exactly when we get there what we should do.
That's a great question.
I agree. And I think that really sometimes some of these kinds of questions can really help to illuminate the processes and the kind of the data and the overall recommendations in a helpful way for other people, not just you. So I would say, yes, you can be, you can act as normal with your family, most likely. So can I ask quickly when your daughter had COVID?
She had it last summer.
Last August.
She and her husband had it last August.
Okay.
She's too young to get the shot now. Mm-hmm. Yeah.
So from what we know, so obviously the other three of you will all be vaccinated.
Right.
And your daughter probably will still have some degree of protection. We think the data is that probably what we know very well is that in the first 3 months after a symptomatic infection, you probably have very good protection from getting disease again. The longer it goes out, we don't know, but she's probably very well protected for at least 6 months in most cases. Again, the around the edges is people who have immunosuppression or just don't mount a good immune response. Just statistically, there's going to be a small proportion. So in that case, absolutely, I would say this is what the vaccine is going to bring to us, is that all of you are vaccinated. If you're doing everything in the interim when you're on your travels there to protect the people around you, you all will be fine, and you should act as such.
And when we come home, should we quarantine ourselves?
No, there's no need to quarantine. So now the CDC has made that clear. The science has probably been there for a couple of months, but the CDC now has said that even for fully vaccinated people, so 14 days past your second vaccine, there's no need to quarantine, even with a high risk exposure. So, this is even assuming that you would have a high risk exposure, which you may or may not in your travels. But even if you're assuming you did, there's no need to quarantine.
Okay.
Just follow your normal procedures. Go ahead.
So she's about 6 months. I mean, it probably will be about 6 months since she had it. So you still think it's okay?
I do. I think it's likely to be fine. I think that because the risk that you would have in transmitting to her is going to be less than probably whatever she's doing, unless she's, holding herself up because she has, immunocompromised. Yeah. So, I mean, if she's just going about her daily life normally, she has more risk from being infected in her daily life than she does interacting with the three of you.
Okay. Thank you.
Excellent.
That's great.
Bring
I think
smile to our face.
that's great. I think Jean, you're next. Oh, you're on mute, Jean.
During that period, from when you get your second shot till you say it's about 2 weeks till it's effective, how safe are you during that period?
Yeah, so this is one of those things where I think like we can be really clear, and we have a few extra seconds to kind of to go into a little more detail. So, now the data is such that even after the first vaccine, the first shot, you probably have 60 to 70% protection from symptomatic disease with after 7 to 10 days from the first. That second booster vaccine, the second one that you receive after 3 to 4 weeks, provides that added protection in the near term. So it gets that efficacy rate of symptomatic disease up to the mid 90s after 2 weeks past that. So it's just this incremental increase. So after that, 10 days or so after your first vaccine, you're already pretty well protected from symptomatic disease. And then since I have the opportunity with this question, I want to also be really clear about something that I think is not very clear, or we're not doing a very good job as public health officials selling this. Once the vaccine is fully, you get your 2 shots and you wait your 14 days, there is almost none. And I think there have been 0 to this point documented cases of death due to COVID. So whenever you're hearing these numbers of 95%, how much effectiveness is there? They're always talking about symptomatic disease, the chance that you're going to get sick with even a mild COVID-related illness. The rate of severe disease, ending up in the hospital with significant complications, needing to be on a ventilator, is exceedingly small. So again, in the 30,000 person studies, of which 15,000 were vaccinated in like each of these trials, there may be 1 case of severe disease and 0 deaths. So in all of the patients that have been fully vaccinated, I know of 0 patients that have died of severe COVID. And that's something we need to be really communicating, that all these numbers, and we talk about, with the variants, we go down from, 95% effective to 60% effective. That's related to symptomatic disease, your chances of getting a cold. Still, even with variants, these vaccines are so effective that they don't almost never lead to severe disease or death. So that's really important. So you have a significant amount of protection, even after 10 to 14 days after your first dose of vaccine. And really that booster dose is in the near term, increasing your protection, but also the key, what it's really going to do, which we're not going to know for quite a while, is that it's going to lead to a longer time period of protection after the vaccine. We just don't know what that is yet.
That's Jean. Does that answer your question for you? Great. Other folks, Steve, you have a question, then Joe.
The question I have is,
Susan.
Yeah, I'm wondering, that's all right, because Steve's listening. I'm wondering, I went through all this business working at the hospital where we got our 2 shots and everything. And I really don't have a clear answer. Are we going to have to go through this again next year? Is this going to be a yearly thing? Because this 2 shots, truthfully, it was a lot. A lot of us got really sick, especially off the second shot, where people actually missed days of work and had to use COVID pay. And that's what I'm wondering. And then my husband and my father-in-law haven't even been able to get the shot yet. And they're both very high risk. So then all the high risk people will have to get it then yearly as well, I assume. Just like the flu shot.
Yep. So go ahead. Is that all?
And do they think they're ever going to get it where it's just 1 shot? Or don't they really know yet?
Good question. So I'll start with vaccine protection and duration. So the reason that you can't get a good answer is because we don't know. The duration of protection, we've only had these vaccines for a matter of 6 months. So the fact that, we don't know is not surprising. And you'll hear multiple things because we'll all of us who have looked at data and thought about it and discussed have slightly different guesses about what the duration of protection is going to be. I think what what I hear from vaccinologists and experts in this sort of subfield, of which I am not one, but I think that the most kind of consistent guess that people have, educated guess, is that probably we'll get multiple years of full protection because of the significant efficacy that this vaccine has in the short term. There's a lot of optimism that there's going to be multiple years of protection at a high, level. So again, especially preventing severe disease. So we will see. We just don't know. I don't know. That's one of those no one knows questions. But the guesses that I hear are anywhere from a year, but out to 2 or 3 years before one would need to be revaccinated. Now, with variants, there's a possibility that there's going to be a recommendation next year for everyone who's gotten their vaccine series to get a booster vaccine in order to give higher rates of protection against the new variants. If we get to a point in 6 months where one of the new variants or multiple of them are becoming the predominant vaccine strain, then they're going to want to, redesign and reformulate the vaccine in order to provide a high level of protection for new patients getting it, but also for those of us that have gotten it before. So it's definite. I am actually expecting that probably most of us are going to get a booster next year because of variants, not because of the ability of the original vaccine series to cover the original kind of COVID strains. But I'm expecting that duration will last longer.
And my one last question is, I was curious because I was under the impression, because they do give us a lot of information through emails, the first shot was not the same as the second shot, because the second shot, I'm assuming, must have been a little different because most of us that got sicker at the second shot, more symptoms than the first shot. So I'm assuming they're actually a different type of vaccine for the 2 different shots. Is that right?
No, they're actually not different. So it's the actual product that you're getting injected is exactly the same dose, same everything. The difference is your body's reaction to it. So you mentioned, I got my vaccine series already because I work in healthcare, and I was down for the count for about 48 hours after my second shot. So I know what you're talking about. The reason is because the second shot elicits a more robust immune response. The first time your body sees the vaccine, sees those products, it's only able to produce, as much of an immune response as it can. The second time, it's already seen that before. And so that's the whole idea. That's sort of, that your body's working. You become a bioreactor for creating an immune response to that virus. And because it's seen it once, that shows you that the first vaccine worked well because your body responds very strongly to the second one in developing more antibodies and responding quickly. And so that's why most of us see a more robust response with the second. It's not what's being put in our bodies, it's our body's response being different to what we get, the same thing.
Because in Pennsylvania, they accidentally gave people the second shot first, and then they weren't sure what they were going to do because and that's why I wondered if they were different, because they were saying, second shots for their first shot instead, and that's why we were kind of wondering. And then well, that kind of explains that, because they really didn't explain that like at the hospital. We just knew we had to do it. Okay, well, I'll let you go because somebody else probably has a question.
Thank you.
Thank you.
Thanks. I think it was Joe. You were next.
Yeah, so I have questions relative to this concept of herd immunity, right? We've heard a lot about herd immunity. I mean, that's sort of a alliteration, but never mind. And early on with vaccinations, we were hearing Fauci say October seems to be this hurdle. Can you speak to where you think we need to be numbers-wise in order to achieve some concept of herd immunity, one? And two, can you talk a little bit about, from a historic perspective, and I say historic because the only thing I think we have in measurable time medically to compare this to, right, is 1918, right? And so-called Spanish flu. I'm just curious what the science tells us about herd immunity in a comparative standpoint as well.
I'll actually take your second part first because we don't really know. With respect to 1918, there wasn't enough, we just don't have enough data at a level that we would need on that historical event to be able to understand, how to compare herd immunity or what's necessary with this virus or this pandemic to that. The other thing is that flu pandemics are a lot different in terms of the way that they operate. So, herd immunity depends on a lot of factors. So it depends on the robustness of the immune response you can generate, the R0 or how easily the virus can replicate and move through populations. And they're just very different with flu pandemics or with flu in general than this coronavirus pandemic. So I can't really speak to comparatively, and I don't think that anybody can reliably speak to that because we just don't have the information because we're 100 years, earlier in terms of technology. So what do we need for herd immunity? I think, again, you're going to hear various opinions, again, of which I am going to distill the opinions of the experts that I trust the best. And I think that most people give a percentage of immunity that's necessary in the population to control this virus between 60 and 70, 75% being necessary to achieve herd immunity. Now, again, herd immunity is a complicated concept, but the idea is just that we can prevent essentially ongoing transmission or arrest ongoing transmission at a significant rate because we have enough penetrance of immunity in the population. So what we probably don't need is to achieve 60 to 70% of the population being vaccinated to actually see herd immunity, because we probably have a significant proportion of the population, as we discussed in Marilyn's earlier question, that has had COVID, and so therefore has some degree of protective immunity for a period of time until they can be vaccinated. And so the best estimate that I've seen is around probably 20 to 25% of the population, something like that, having already been sick and having protective immunity at this point for a period of time. So if you take that, then we probably need, and again, some percentage of those people are going to get vaccinated as well. So it's not perfect, but we probably need 40 to 50% of the population-ish to be vaccinated before we can expect to really see herd immunity. Now, that again doesn't mean that we won't start to see incidence rates fall significantly in the interim, because as that percentage slowly increases, the ability for the virus to replicate and spread in groups is just going to slowly decrease. So I'm expecting that we're already seeing this decrease. We're about to get to the spring where we're going to be able to be distanced a little bit more, and we're going to get outside, and hopefully the incidence is already creeping down now, as we discussed. Hopefully we won't see another significant resurgence. Again, the only concern for that would be with variants. So, my expectation is that we will continue to have a downward trend as vaccination rates pick up, and we'll eventually get to herd immunity once we get again, another 40 to 50% of the total population vaccinated. So whenever we get to that point, is probably when we'll get there. And again, that's concern for symptomatic disease. We're not going to have any children who are going to be vaccinated because we don't have any licensed vaccines. But if we know that they don't transmit quite as well as adults, especially kids under about 6. And so even with none of them being vaccinated, if we can keep getting the community rates down, then I would expect that the risk of large transmission events is going to be very low going forward.
So just another forward question that takes into consideration history. Well, in some of the stuff that I've read relative to how the Spanish flu ended up being as bad as it was, where it was as bad as it was relative to particulate matter and pollution. And the cities around the country that had the worst, it had the disease the worst. So Pittsburgh, Chicago, Los Angeles, New York, big cities. We're seeing the same thing today. I'm curious if you've seen any data today that indicates the same, because, you know, from a behavior standpoint, the diseases are similar, right? They have these congestive issues, and you know, quite frankly, I'm suspect. I do some genealogy, right? I'm suspect that the people that died in that time period that I was related to, that were given the diagnosis of pneumonia, were really killed by something like this global pandemic then. And I see the same thing. I think at the end of the day, maybe when we've got this thing in the rearview mirror, we're going to look back on this, and that this is really an environmental justice issue. We need cleaner air, and we need to get there with resilient solutions, and can't have just one solution. So anyway, I'll get off my energy soapbox, but because that's what I do. But the point being, I'm curious if you've seen any data that overlaps particulate matter and cases or any kind of flow with respect to that.
Yeah, what I can say is that what we know about coronavirus transmission rates, especially compared to flu and really most other respiratory viruses, is that we've been surprised that transmission through surfaces is low compared to other respiratory viruses. But particulate matter, of course, is not that, right? It's meaning that there's, you know, more chance of respiratory spread because we have larger particulate droplets. So again, not my expertise, but I think it's difficult to say because there's so many confounders, right? Like why would spread be worse in big cities? Well, there's also large congregations of people in big cities compared to other places. So there's a lot of confounders that could be making that a complicated and very difficult to draw conclusions about what the reasons might have been.
They're burning more diesel fuel. They're burning more coal to create energy. You know, I mean, we burn 35% of our energy in Pennsylvania comes from coal. I don't know what it is in Nebraska, but it's 35% here. It used to be less than that when we still had nuclear online. And, you know, the gas industry put the nuclear industry out of business. So anyway, but I'll get off my high horse. My point being that those things, diesel fuel exhaust, all of that stuff leads to more people getting sick because there is a inability to fight something that attacks our immune system.
Yeah, the
I
other
don't know
thing
what that is. I'm not the scientist. I'm the energy guy, but I think there's an environmental message here. I think there's one that says we need to clean it up. We need to broaden our mix of cleaner fuels and do the right things.
I'll be quick. I think that the only other thing that I'll definitely say is that clearly those things absolutely lead to further respiratory infections, lead to respiratory disease, which then makes infectious disease more likely to occur and be more severe in patients like that. So that is a connection that's absolutely indisputable. So there's no question about that.
Other folks want to jump in here. Bryan, I think Sue had asked a question maybe about single vaccine.
Oh yeah. Sorry, I didn't get to that. So in terms of single vaccine, there is the AstraZeneca vaccine, which is not yet even been applied for licensure in the United States, is a single dose vaccine. And so there's hope that will come, online at some point, or they will apply for licensure here in the U.S. And so that is, promising. And certainly the data that we have that I alluded to earlier on our current vaccines, which are 2-dose series, there's now data emerging even just this week that we get, more protection from the first vaccine than, at least in the immediate near term, than we knew before. And so I think that it's likely that we'll be able to, going forward, it just depends. I mean, I think it's hard to say. Probably we'll continue to try to have use the vaccines in a way in which we can get maximal efficacy, which is to get 2 doses. And probably in the long run, we know that a prime boost, so getting 2 vaccines, one to prime your immune system, the second to boost it, just like I talked about in the earlier answer, leads to more robust and longer lasting immunity. So that's sort of the ideal, but we're fighting against, we need to get as many people vaccinated with even 1 dose as early as possible. So I think what we're learning is that probably the single dose helps a lot. And so what might be a reasonable public health measure would be to try and get more people 1 vaccine earlier. And then once we have that, the ideal long-term strategy would be to have a multi-dose series so that we can have best available kind of efficacy rates and long-term durability of the immune response.
Great. Kathy.
Oh, sorry. I thought I took it off. The question is between the Pfizer and the Moderna, which is more efficient and would provide the best possible scenario?
Yeah, for all intents and purposes, they're equal. It's very hard for me to say. There's basically no reason to have any. There's almost no way to tell them apart in terms of their efficacy rates, in terms of their adverse event rates. We can split hairs and talk about some very, very tiny differences, but really they're both excellent vaccines. I would get either, I think, and feel very confident that what you're receiving is the gold standard for COVID vaccination, actually.
Thank you.
Mm-hmm.
Just to raise another area of conversation and Bryan's specialty, Bryan, how are you feeling about therapeutics with folks who have contracted COVID?
Yeah, so therapeutics are a complicated area. I think they're key to being able to, in the long run, feel like we have a handle of this disease, because it's going to be with us. It's not going to go away even after years and years. And so we're going to continue to have pockets of people that get severe disease. And so we need therapeutics. And so I'm very excited about the data around the monoclonal antibody products. So these are products that work best in early disease. And so we give them to patients, at least now, since the data we have is that they significantly impact the rates of hospitalization and severe disease that develop among high-risk individuals. So that's the elderly, those who are obese, those with certain medical conditions like respiratory disease, like we mentioned earlier, that make it that give you more severe disease. So if you develop symptomatic COVID and you're in one of these high-risk categories, I recommend that you seek out monoclonal antibody products to receive in order to prevent hospitalization. So the data on that is great, are very encouraging. For every dose of monoclonal antibody, or for every 15 doses of monoclonal antibody that we give to high-risk patients, we prevent 1 hospitalization. That's the data. So then we have, a number of drugs that we give now for patients who are in the hospital. And it depends entirely on what your, how sick you are and where you are in disease. So we have remdesivir, which is an antiviral, which we give as, again, early in the course as possible once you've been admitted to the hospital. But you'll also hear a lot about steroids, so like dexamethasone, and then other anti-inflammatory products like baricitinib or tocilizumab. So those are given, again, to patients who develop more severe disease, and we try to give them at certain points in the disease process in order to prevent more severe complications. And so, I think that we've been really successful in managing severe disease, not only from a therapeutic standpoint, but also from We know how to just take care of these patients better. We try to keep them on non-invasive ventilation, like in the hospital, on masks with oxygen instead of intubating them. We know that outcomes are better. We know that putting patients on their stomach when they're having lots of respiratory distress helps. And then we have all these therapeutics now that we know better when to give them. And so whereas early in the pandemic, the mortality rates for patients that were hospitalized with severe disease were in the 30 to 40% range, now they're in the single digit to 10% range. So we've made a lot of progress on that front.
That's great. That's very encouraging, I think. Other folks with questions?
I have a question.
Yeah, please.
Question back to the variants. My brother-in-law's Veterans Administration physician in Tennessee, and this week he was talking about homegrown variants versus the United Kingdom and the South Africa, that there's more of a concern about variants that we have coming out of the United States. Do you have any information on that?
Yeah, so I mean, there's a couple of variants out of California is where they're described. The one that's probably most concerning is from California in the US. And so, how concerned to be? So I think there's two things to think about when you're thinking about variants. So one is what's their impact? And the second is what's their degree of penetrance in the community. So for the UK variant, B117, what we know about it is that it's widely distributed now. So it probably was an early variant. It popped up probably very early in the pandemic. And we're only now realizing that it's pretty much everywhere. And so its penetrance is high, and its impact is on, its known impact is on increasing transmission rate. So it's just a more efficient at spreading disease, but probably no more severe. Maybe a little, but that's still a little bit unclear. So this actually I would say, I think many people are now moving from calling the B117 variant from the UK, not a variant, but a strain, because now strain is sort of what we call it that once we can sort of say it has a different biological property. It's not just different in terms of its genetic code, but it has different biological properties in the community and in disease. So that's what we know about the UK strain. So it's probably the most concerning one because it's the most widespread and we know its impacts. The other variants we know less about, but they're also more concerning because they've picked up more mutations in significant regions. So especially the South Africa variant's probably the one that's best described, but the one from California is also similar in that they've picked up more mutations, and they, in studies, lead to they're able to evade immune responses better. And so like our vaccination immunity that we receive has some significant decrease to it in terms of its degree to protect against symptomatic disease. But those variants are not as widespread. So they're much more, they're in pockets, they're in small percentages here and there. So they're not very widespread yet. So they're more concerning from a epidemiological perspective in terms of their ability to evade vaccine facilitated immunity. But if we can get on top of our vaccination as quickly as possible, then we can prevent them spreading widely and hopefully mitigate their impact. If you have a follow-up on that, because I want to make sure I answer your kind of question in detail. It's kind of complicated.
Bill.
Bryan, assuming that your church is closed, when would you plan on reopening your church?
Yeah, so if you remember the last time I kind of mentioned that I'm working, I didn't mention it this time when we started, but I'm on the church council here for my church. And we have a lot of, ongoing discussions. Our church is open, but with masking and distancing and limitations on the numbers of people that can attend.
Bryan, that's about where we are. I think the current limit is, there's a percentage that works out to 45 people, I That's my understanding. Go ahead. Sorry.
No. I appreciate that. It's good to know kind of what you guys have as your kind of baseline and what you're working with. So, and that's been my kind of contribution. I've worked really hard to try and convince my congregation here, which is probably not as has not been as willing to uptake some of these recommendations as you guys. So that's where we are, and we haven't had we've had a good number of people get sick in our congregation, but none related that we know of that are related to being at church. So what would my recommendation be? I think that probably, kind of what you're doing and what we're doing now is probably reasonable for, again, a little bit longer. I'm really hoping that, by the spring with vaccine penetrance rates up, if we can get community transmission rates down, to, less than 10 cases per 100,000 per day, then we can get to a place where we're at, pretty low rates of community spread where, we can do a little bit more. Still, we're going to be doing masking and distancing for many months to come until, really, my opinion, and I think the opinion of most public health officials, is that until everyone who wants a vaccine has had a chance to get one. I think that's probably because it's not just a scientific question, but it's sort of an ethical question.
Right.
Do we put people at risk in the community if they haven't even had the chance to get the vaccine yet? So I think probably that's when you're going to see those measures start to be fully removed on the part of public health officials. So we're a long way from that. And again, church is probably among the very high, unfortunately, is among the very highest risk activities because of being in close proximity indoors for a long period of time, singing involved, all of those things. So I think we're going to be doing these measures for a while, but that doesn't mean the church has to be closed.
Right. And you can even worship together. But Bryan, the kind of, I guess the latest stuff kind of out there in public is enough vaccines will be available maybe sometime in July for everyone to get vaccinated. So it might be August before you could expect, I don't know, a kind of worship service with singing and that kind of thing, or would it be even a little bit later, you think?
No, I think that's probably reasonable. I think probably by summer, I'm hoping, again, it all depends on vaccine rollout and availability, but assuming that we can get to, roughly half the population vaccinated by July-ish, or whenever we get to that point, that's probably around the point where community spread will be so low that we'll be able to have pretty much a normal, a normal experience of most activities.
That's great.
We'll probably still have to be, masking and distancing in certain circumstances, or masking maybe, but not distancing. We'll see how it all pans out. But I think that things will get to be more normal once we can get rates very low.
A chat message from Nancy asking about if you would discuss the school situation and getting back to school and that kind of thing.
Yeah, schools. This is probably the most fraught discussion in the public sphere right now, I would say, aside from maybe vaccine distribution. What do we do about public schools? Well, here we're talking probably from two polar opposite ends of the spectrum. So here in Nebraska, pretty much all of the public schools have been open fully since the beginning of the school year, with varying degrees of appropriate mitigation being taken. So most school districts, are really good about being able to require that the students wear masks at all times. They're able to do varying degrees of distancing based on the resources and the physical plans of the schools. Most of them haven't done much of anything with respect to indoor air quality because they can't, maybe they've swapped out some filters, but they can't really change too much in terms of the overall air quality because it's such a difficult physical plant problem. So that's been true here in Nebraska from really the beginning of the year. And what we know from the data from places like here is that rates of spread in schools are actually very low. So if you take the minimum amount of precautions, specifically masking and distancing, most importantly, but then I'll also add in testing. Probably that's another thing that would be, really an important component of a fully appropriate school reopening plan would be testing, especially of teachers on a regular basis, but students ideally as well. And so we've done only a few of those, specifically masking and distancing, and rates of transmission are very low. And so when that started in the summer, we didn't really have that data. And this was an experiment that a lot of the communities like ours did without really knowing how it was going to work. And it's worked pretty well. And so then the amount of increased money you can throw at the problem in order to do these other things like physical plant changes, better distancing, testing of teachers and students, you can have a more and more safe plan. So what I would now say to communities who are more resistant to kind of restarting, and I'm speaking specifically of K through 12 education. I won't speak about universities because that's a little bit different, but especially the younger that you're talking about, especially where those students are probably where it's most important that they go to in-person school, is probably the least risk. And communities where there haven't been schools that have reopened with lower rates of community spread than we've had here and other surrounding states and Nebraska, probably, in my opinion, schools should be reopened with appropriate precautions taken, because now we have the experience from public health to sort of say that these are relatively low risk environments for transmission if you do the right things. We know what those are.
Great. Thank you, Nancy. If you have a follow-up, please feel free to share that. But other questions? We've got about 10 more minutes. It's been a nice range of questions. Maybe we've asked every last one. I don't know. I'll throw out another one. Just Bryan, how are you feeling about things like public health and the CDC, their leadership? Here, Nancy's got another. Should school personnel be vaccinated?
Yeah, absolutely. So I can speak to both of those. So I think that's another key component. So I think my opinion is that probably in terms of vaccine prioritization, and I looked a little bit at what Pennsylvania is, it's very similar to what we're doing, what most states are doing, which is kind of focusing for the most part on patients over 65 and sort of working down from sort of 80, 70, 65 in terms of ages. And then one thing I did notice is that in Pennsylvania, it looked like, and you guys can please correct me if I'm wrong because these things change, that you guys have in your tier 1A patients under 65 with high risk medical conditions as being in 1A, but then in 1B, you have all of those public facing essential worker categories sort of after them. And in my opinion, based on the data and based on not just the data scientifically, but I think when it comes to vaccine prioritization, we have to think about, what's the social good. And my opinion is that it would be wise to put people who are in essential positions ahead of most people who are under 65 with high risk conditions. So there's only a few high risk conditions I would say that are clearly that we know from data that clearly can lead to increased rates of complications, morbidity and mortality. And so those are things like respiratory diseases, obesity, and cancer, sort of active or recent cancer. So those are three that we know have high risks. So those maybe I would keep, but other than that, what we then say is, okay, sure, teachers, utility workers, grocery store clerks, they're not at high risk for serious disease, but the faster we get them vaccinated, the faster we get back to social normality, the faster we get kids back to school, the faster we can get back to church if we can get pastors and clergy vaccinated. So it's not so once we get to that point where we vaccinated the people who are at highest risk of severe disease, then I think we need to prioritize people like teachers who are going to get us back to normality faster. And so now I think this is kind of that inflection point where I would say personally, it's probably just as important, and if not more important, I think personally teachers should be at the top, right after kind of first responders, utility workers, in terms of the groups that should be prioritized for vaccination so that we can get our kids back to school.
Great. Nancy, I hope that's helpful. And then the kind of leadership we're getting, I guess.
Yeah, so the leadership is really welcome. I know I've met Rochelle Wallensky before one time. She's a great, so this is the new CDC director, Rochelle Wallensky, who was appointed. She's an infectious disease physician from Boston. She's been working in Boston for decades. She's a great public servant. She will be a great public servant. She's an excellent infectious disease physician. I'm really excited about the leadership at the CDC. I think, no doubt though, regardless of that, these situations are political, they're going to be politicized. And we've seen that already with respect to school opening. There's already all kinds of discussion. In fact, Dr. Wallensky kind of came in and said, we can reopen, kind of like what I just said, we can reopen schools, we have this data. And immediately, the administration, the Biden administration was like, well, she's speaking personally, she's not speaking on behalf of the administration, because, there's that's the political reality, is their teachers unions are powerful. And so there's always going to be this kind of give and tug and pull between the two aspects. And I'm excited that science gets to speak out and more and honestly, a little bit more than it had before, but there's no question that politics is intertwined intrinsically with these questions, and so it's never perfect. And I don't know that should scientists themselves be making public policy? No. I think that it has to be a group effort with politicians and people who have who are elected and have direct responsibility to the people. So so I'm encouraged by the people that are being put in positions of influence, because I have a lot of trust in them, and in some cases I've known them, at least, if not personally, I've known them professionally, in the infectious disease community for a long time, and they're good people, and they know their stuff, and they're going to speak to it as truly as they can.
That's great, Bryan. On the question of vaccine and its the rate of people being vaccinated, I know there's that's a kind of a growing thing and a tricky thing. And do you have any thoughts there on, your kind of confidence level on that continuing to edge up, or that kind of thing?
Yeah. I think that, it's difficult because the drug companies have kind of stopped saying over the last month or month and a half, they've kind of stopped giving public proclamations about how much they expect to get out when. And I think, I don't have any inside knowledge on this, but my expectation is that they've been asked to do that by the politicians, because they don't want to set expectations that they can't keep, or that are limited by our ability to deliver practically what they say they can produce. So what that means for us is that we don't really have a perfectly clear idea about how the vaccine rollout's going to go. What we get are these things like, the U.S. has agreed to buy, 300,000 doses that should be delivered by July. And so, or whatever, it's 300 million more like, but, right. But anyway, those are the numbers that we get. And that doesn't tell us like, okay, does that mean you're going to deliver 100 million over the next 2 months and 200 million in the last month? It could be anything. And just because they've delivered it, they've produced it and put it in a warehouse, means it could take 2 or 3 more weeks beyond that for it to actually get to where it needs to go to get in people's arms. So, no question, it's ramping up. I think that every inclination or every indication we have on the part of the administrations, both state and federal, are that we're increasing our numbers from 1 million vaccines a day, which is a little about where we are now, moving towards 2 million or so per day. But we really need to get that up, to 2, 3, 4 million per day in order to really get this under control in a matter of months, which is kind of what we're talking about here today. We're kind of expecting that's going to happen, but it's hard to know for sure.
Great, thank you. And then there's another question on chat. What is the current information concerning vaccination in postpartum women and nursing mothers?
Absolutely. So when it comes to, officially the CDC stance is that, it's recommended, but should be decided in coordination with your OBGYN, which is perfectly reasonable. Shared decision-making is the way it should be. Because we don't have data from studies in pregnant women and nursing mothers. At least we don't, well, in nursing mothers, we don't. In pregnant women, we have very few because they were excluded from the trials, but there were a number of women who were vaccinated and then were found to be pregnant afterwards. Mm-hmm. So we have very few numbers. And so it's absolutely reasonable for there to be shared decision making. However, there's no indication that that in pregnancy, there's no reason scientifically that there should be any kind of issue or problem with vaccine receipt in pregnancy. There's no reason to expect scientifically, and there's no evidence to suggest from this or any other similar vaccine that it would lead to problems in the growing infant. And we also know that pregnant women have a significantly increased rate of severe disease. So I want to say the number's 8 times for age adjusted. So if you've got a 30-year-old healthy person who's pregnant, their age adjusted risk of severe disease is I want to say it's 8 times. Don't quote me on that, but it's something like that. It's a number of times higher than someone similar age and comorbidities. So they're much higher rate. Sorry, are you still getting me? Sorry, I was getting an alert on my computer. So I would encourage them to be vaccinated for all of those reasons. In nursing mothers, even more so, because in that case, in the pregnancy case, you can't provide protection to the infant. So the placenta will prevent any antibodies, significant numbers of any antibodies actually protecting the baby prior to birth. However, in nursing mothers, antibodies that the nursing mother would produce will be excreted in breast milk. And so you can actually, by getting vaccinated, protect your newborn infant to some degree with transmitted antibodies. So in that case, again, it would be encouraged to have them be vaccinated, again, with little to no risk. In my opinion, no risk, but we can't say that with confidence because we don't have the science to back that up. But there's no reason to expect there would be risk. So
terrific. I think we're just about out of time here. Any last question? Somebody who hasn't had a chance to jump in. Yeah, well, I know if we all very much appreciate Bryan's time with us. It's just so nice to speak with a scientist referring to data, and here's what we know, here's what we don't know, and here's what the literature says. So, and just with such ease and also easy to understand. So thanks so much, Bryan. I know your community, if you weren't with us the first time, Bryan is a practicing Orthodox Christian where the liturgy is typically sung. And so no singing is especially hard on such communities. So hope y'all are hanging in there all right.
Yeah, it's been okay. It's been, I've served on parish councils in many years over my life. And this has been by far the most challenging, most difficult year I could have imagined to do that, but probably also the most rewarding because I feel like it helped the community to have the expertise to be able to speak to. So yeah, thank you. It's been okay. It's been fine. I'm glad to have been able to help.
Well, I know you've been very helpful, and it sounds like you've hung in there and what sometimes can be frustrating meetings. Yeah. All right. Well, why don't we close with prayer, and then we can thank Bryan again. I'll close this. Bryan, would you be interested in closing us with prayer? Maybe I don't want to put you on the spot.
Sure. No, that'd be fine.
Great.
I'll do a little extemporaneous and then maybe a quick Orthodox prayer.
Sounds great.
Dear Lord, please watch over us in the days and months ahead. Please help us to remember all those that we have lost, or that will be dealing with difficult issues related to COVID in the future. But please watch over us and protect us in the days and months ahead, both ourselves, our communities, and those that we're looking out for. O Heavenly King, the Comforter, the Spirit of truth, who are everywhere present and fills all things, treasury of blessings and giver of life, come and abide in us and cleanse us from every impurity and save our souls, O good one. Amen.